What is the real practice on pain management among all of these painful procedures happening in the emergency department? This is a good question we're asking ourselves this afternoon. To highlight a few on the practice, I try to cite a few examples, and probably you can remember many, and later in the discussion, be part of it. So incision and drainage is commonly happening in our emergency department. Many patients comes, we need support for the pain from these abscesses. What do? I don't want to believe that we all still do under pole. For those who are not aware of Swahili, pole, it's something just like a sorry for what we're doing, sorry for causing a painful procedure. But is that the way really should control the pain at ED? Probably that's not the case. Another painful procedure, do you remember when you have patients with paraphimosis and when you try to reduce it? What do we normally do? Are we keeping in mind that these are painful procedures? We need to do something for pain before we approach this. But what do? Just a moment, it will be a way. If that's the way we should be, if there's strategies for pain management, try to reflect and think whether this is a standard or what we should do. Lumbar punctures, it's not a common procedure at ED, but we're supposed to do it. And some of the areas, we do lumbar procedures for our patients, lumbar punctures. But what do we normally do? Do we consider this a painful procedure? Probably we need to give something for pain. But what is the real practice? Hold on, just a bee sting and it will be over. If that's the way we should do, this is an important question to reflect ourselves. Probably the last but one, as an example, we all and most of the time do urethral catheterizations. Are we keeping in mind that these are painful procedures as well? Do we consider giving something for pain for this? But what we do, come on, just be a man. It's going to be a few minutes and it's over. So these are things which I try to highlight this afternoon and keep in mind, are they considered as painful procedure? Do we have strategies? Do we have standards to care for all of this at our ED? So maybe to take over, everyone should assess himself, how comfortable are we in understanding the pain? And we talk about understanding the pain, there's many things to consider on this. The pain assessment, all the age extreme from pediatric to adults. Are we aware or are we good in differentiating between acute and chronic pain? And how do we approach these two things separately? What do we do when you give the pain medication, it doesn't work? Do we have a standard or strategies to approach again on this? And many more things you could think about pain management. So maybe because of the broad aspect of the pain management, particularly in pediatric at ED, we're not going to cover all of this. Few things will be our focus today. And what are these? One, at least by end of these few minutes today, you should be able to explain the importance and the strategies for pain management. But also, what is the current practice on pain management in our ED in Tanzania particularly? And lastly, be able to discuss different strategies for pain management at ED. This is going to be the focus of our talk today. The rest, I think, is all for us to search more and get how we should manage this. So why do we need a standard in strategies for pain management in the emergency department? It's very important on different contexts. One of the reasons is pain is very common presentation at ED, but unfortunately, most of them is under-recognized. And because of this, it also brings a patient safety concern, particularly the special population and minorities. Those disadvantages when it comes to ED, do we really do fair for them in terms of pain management? But more important, untreated pain, we should not forget that it can lead to adverse sequelae in the future of this life for these patients. So it's important to have a standard and strategies at our EDs. But also, we should also remember it's not that much easier just to ignore the pain to our patients. Because if the patient doesn't scream at your ED, it doesn't mean that this patient doesn't feel a pain. Because the expression of the pain from the patients can be affected to many things like cultural aspect, religious, socioeconomic, All of these could influence pain presentation among our patients. So importance of having a standard assessment, we can't overemphasize, because if you don't do this, many patients will pass out of ED with the pain and probably we miss them. What are the importance of oil on the pain management? The other things we should remember, patient response to whatever treatment we give. Also, it's not only influenced with the pharmacological of the medication we give, there's other things apart the pharmacology, equally important. How do we communicate with the patients? Would affect the response to what we're giving. But more important, the responsiveness or responsibility we take for our patients, the way they see how we care about them, this also could influence the treatment we give. But more important, how we empathize what the patient is going through at that particular time. Equally important instead of the medication we're giving. So all of these makes us to make a broader aspect of thinking about the pain management. It's not only the medication. Though also we should not forget that why we need to have painful strategy in the standard. If we mismanage this pain, have very significant clinical effects to our patients. One of them is this unmanaged pain could lead to worsen of the tissue and organ injury and probably delay healing of those injuries if the pain is not well managed. But also we should remember a prolonged or repeated exposure to pain for these patients when they present at our hospital. This could lead to a future chronic or recurrent neuropathic pain. It's important to capture and manage pain effectively once the patient present to the ED to prevent these complications to our patients. But more important as well, probably last but one, that if we don't manage well, the clinical effect of this pain could lead to many adverse events in the future. Depression and anxiety, very common documented for those patients who their pain were not managed well. Post-traumatic stress disorder, arrhythmia, cardiac ischemia, and more and more. There's so much evidence in the literature that mismanaged pain could lead to harmful clinical effect to our patients. Colleagues, let's not ignore the pain for our patients. So what is the context of Tanzania in terms of pain management? Well, to start with, no much study has been published on how we do to the study, to pain management. There are a few studies I'll try to cite, which was done in Tanzania. One of the studies we did at Muhimbili National Hospital, like a few years back, regarding pain management and assessment at ED. What we found in this study, this was done to patients who present with the pain as complaint. But the good thing is pain assessment, we saw good in doing that. Almost 100% of the patients who presented at ED, we doing pain assessment on arrival. Unfortunately, half of them, they will just have their pain managed. Unfortunately, half of them, they get their pain managed when they present at ED. This is a sad news, colleagues, and probably we should find a way to get over of this. The other study was just done like 2 years back. We looked about factors associated with the provision of pain management. This was among trauma patients. So I didn't get pediatric specific, so I tried to cite an example for adults just to get overall pictures about pain management. And on this study, what we found out, among these patients who presented at ED with the pain as complaint, and these were trauma patients. Yes, only 30% of this patient, they get pain management before arrival to ED. Remember, this patient, they had injuries. They went to prior hospital before arriving to Muhimbili National Hospital. So when they pass to these peripheral hospitals, before coming to ED, only 30%, they get pain management. The rest, they arrive at ED without pain management from the previous hospital. But when they reach to us, and this is the good sign that this patient, they're having pain, almost all, when we asked about the pain, they all presented with the pain, regardless whether they pass through hospital before or they didn't pass. They all has a pain at ED. But what did we do? Again, half of them, they get managed at ED. And half of them, although we assess pain for them, but we didn't manage. So colleagues, this is just a highlight of the context of pain management in our setup. It's unfortunate. Do we treat them? Probably not. And what we find out, again, 50% they get treated, and the commonly one medication we use is paracetamol and opiates. This is the only option we have. Maybe there's something also in terms of, I don't know, training or awareness, the approaches to pain management. Therefore, there's so much to be done in terms of pain management in our ED. And we ask ourselves, if we can assess pain to our patients who arrive at ED, why then we undertreat them? Is it subconscious? Or is it intentionally we ignore them? I don't believe that we ignore. It's something we need to work out to improve pain management at our ED. Is it lack of training? Is it because we are lazy that treating pain, it takes extra time? No, we need to improve, colleagues. And if you look on the literatures, try to find out what could be the other reason why these patients, they are not being managed. This is not in Tanzania, but I try to look what other places in terms of pain management, they found out as a reason why we don't treat pain. There's one study done by Tenaba et al. Among the nurses at ED, and they try to just look on the understanding or deficiency in knowledge about pain management, particularly the addiction, tolerance, and dependence, but also analgesic effects of those medications. And what they found out, the practice or the knowledge of the score was related to educational level. So probably training, something should be considered according to this study. But also they try to find out what the barriers for pain management. About 50 or half of these practitioners, the reason is just because they didn't give pain management, they were scared that the doctors, when they come to assess this patient, they will not be able to pick the diagnosis. Actually, this is not the practice. And if you do this, I think it's very unfair to our patients. Is it because of the medical dogma that opioids could lead to addictions? And this is the question I try to ask myself. Maybe we should ask it also among ourselves. And the question is, do we really aware of the difference between tolerance, dependence, and addictions? Maybe we overuse the word addictions. Rather than this patient, they just have a tolerance. So just to highlight, tolerance means what? It's diminished analgesic effect. These patients, they just need increasing dose. It doesn't mean that they're addicted. And labeling them as addictions, we unfair to these patients. But is it a dependence? Dependence is just the means that this patient, they reach at a certain level on analgesia, but how we stop this, they need a gradual dose rather than suddenly stop of the medications. But they're not addicted. So what the real addiction is the behavior, and not just something could happen over a few days of opioids management. This is the pattern of drug seeking, and it takes a few months, probably days to months to get these addictions. It's very rare to happen within a short time of hospital management. So maybe we under or overstated the addiction to our patients. And before I finish, I remember one thing also we used to be taught at medical schools. I'm trying to remember what happened, that maybe the infant, they don't feel a pain. For real? Not true. If you read the studies and pathogenesis of pain, even the neonates, they still feel the pain. So we should not really consider as minority and probably not to be treated because they're infants. That is unfair to our patients. So where we are, do we really have, what do we take in terms of pain management? Do we have a standard of how to manage pain? Are patients treated equally or in response to the pain they're feeling? Lastly, do we have strategies to control? To have strategies, you need a goals, you need a target, you need monitoring so as you could assess whether you reached a goal or not. When we manage a pain to our patients, do we really have a strategies what we want to achieve? I think this is the key question we need to ask ourselves as healthcare providers. And you remember, what we take as author is that doing good for our patients. So if we fail to manage pain, we're not doing good for ourselves, but also for our patients, because we are against our code of conduct. Thanks, colleague. Maybe to give this into context, let's see a few cases and how could manage in terms of pain. Let me take this opportunity to welcome my colleague, Prof. Mike, to come and share what is next in terms of pain management. Thank you.
Thank you. Thank you so much for including me in this lecture series. This is wonderful. I've been giving these talks on pain for over 25 years, and I still find it incredibly fascinating. Fascinating because there's such variability in the patient's pain experience, and also their treatment response. There's also incredible variability in provider practices. And I think that the title for this talk today was just spot on, that it was a focus on what is the real issue here. And the standards that we talk about are both institutional standards, but also personal standards. What is your own personal standard of care, as well as what are the strategies that might be useful for different patients, knowing that we need that flexibility. So hopefully the cases that we talk about in the coming half an hour will help illuminate some of those things. This is the participatory part of this. So we want to get everybody involved in wrestling with these cases. We need your input. I certainly do. So I'm going to share my screen and we're going to get started. Uh-oh. Let's try to refresh and do that again. There we go. Come on. All right, case is coming back. I might have to wait a second. I'm going to skip ahead to some cases that we thought would be particularly useful for today. Here we go. All right. All right. And most of these are patients that I've actually seen myself. This is one, this is a boy that I saw that was on an international flight, and halfway over the ocean, he went to the bathroom and unfortunately got his penis caught in his zipper, spent the rest of the flight in agony, and came straight to our emergency department. So we have some choices about what to do as he arrives off the stretcher at your hospital. How would you approach making him feel better and facilitating the removal? So I wonder what your thoughts are. I would love to see your input in the chat. Would you give him PO Versed? And how much would you give? Would you give him intranasal fentanyl? Would you give him nitrous oxide? Would you place an IV in? What are your thoughts about that? I'm looking in the chat for anyone's input about how you would approach it, or none of the above, or something else. What would you do with a patient like this? Hard to get near him. He's so apprehensive. He doesn't want to do anything. I'm not seeing any answers yet. I'm wondering what, maybe you've never seen a case quite like this before. I don't get it every day. Well, I'm going to go ahead and talk about a few things. Well, I see one intranasal fentanyl. Okay, so it sounds like that's an intervention that you all have available. Fantastic. So that definitely could help with his pain. Midazolam, okay. All right. So I'm going to talk about one possible intervention that you may not have right now, that I used for this particular patient, and it was amazing. And that was laughing gas or nitrous oxide, a very, very inexpensive intervention, just a little different to those of us who work outside the OR, but not all that different from other things, and that it's a medicine. It's just delivered in a different way. There's a lot we don't know about nitrous oxide, but it is one of the oldest medicines that we use today. We know that there are some unique receptors to nitrous oxide in the central nervous system. It does seem to have some effect on opioid receptors. It does not require metabolism from the liver or kidneys, so it is safe to give to patients who have problems in those areas. It's not stored in the tissues, and it's eliminated almost immediately. So it's a great, quick intervention. And this particular child, when I gave that to him, he went from terrified of all of us to actually laughing through the procedure as we relieved the problem. So a nice quick thing that didn't require waiting or an IV or an injection. It's simply just applying some gas, and within minutes he was feeling better. Okay. Let's see. Here we go. So nitrous oxide, we'll talk a little bit about it. It is most potent in its anxiolytic effects, but it also has some analgesic effects. So about 50% of patients will have some amnesia. Here we go. Here's another one. This is the one I see all too often. A hyperactive 2-year-old with a chin laceration requires just a few stitches to make this better. But he's already been through some bad experiences and he's already quite agitated and anxious. You want to do a good job. Which of the following things can you do? Would you use some oral midazolam? And the dose I suggest is 0.5 milligram per kilogram. Just distract him, give him a shot of ketamine, or give him IV propofol. What are your thoughts about that one? What would you do? Or, of course, you don't have to do any of the above. You could just hold him down and do your best. But it's a chin laceration, and as you know, chin lacerations are particularly challenging. It's hard to immobilize the jaw. So I see a vote for ketamine, a couple of ketamines. Wow, several. Okay. It's amazing to me that when I first got started, propofol, we didn't have ketamine. We certainly didn't have propofol as options. And the patient that I have in mind, this one was in my residency, and we didn't have either one. We did have midazolam for sure. Yeah. So ketamine definitely would do it. In the case that I have in mind, I was working hard to try to get this kid to hold still, couldn't do it. And one of my colleagues walked in, another resident who came in and started to talk to this young guy by telling a story. Took a glove off of the glove box, out of the glove box, blew it up, started drawing on the glove box, a picture of a rooster, and started telling a story about a rooster. And this child went from agitated to hypnotized and didn't move at all. It was remarkable. We had already given him medicines. We had given him all the sedation medicines that we had at the time, and it didn't work. But in this case, he did great with just that. It didn't require anything else. So a few things that I think are helpful. One is an article that occurred in the Washington Post from a kid that was admitted to the hospital. And they just shared this with the public, saying, these are the things that really bothered me as a patient from a pediatric perspective. They didn't like to be surprised. They wanted you to think about, is there a better way to do things? They felt like people weren't always honest and sometimes minimized it. So when you said, oh, stop it, it doesn't really hurt, it actually makes things worse. It's a sense of bodily autonomy. Also, this positional situation we get when we are standing above them that makes them feel vulnerable. Trying not to wake them up so many times, and dressing normal were some of the other things that they requested. But here are some non-pharmacological things that are really useful. So first of all, even a child as young as 2 years of age can benefit from some level of explanation, although they can't get the concept of something that's painful briefly is worth it. Encouraging them to express their feelings is good. Give them choices whenever possible, being mindful that you have to give them choices that you are okay with as well. So if it doesn't matter right versus left, let them choose that. Get them to start breathing deeply and say something that's positive can help as well. But don't promise that there won't be any pain, because it's hard for you to know that. And once they feel that that's been compromised, you will lose your credibility. Don't invalidate the pain that they seem to be expressing, and never, ever use our treatment as a threat that if you don't do that, I'm going to do something that's painful, because we don't want to conflate our intention to make them feel better with their fears of being harmed by you. This is a picture drawn by a child from their hospital experience. What do you notice about this picture? What do you see? This is now, I'm asking you all to be an art critic. I will point out a couple of the things that people often notice and see if you all can see it as well. But if you see this picture, you see it obviously, you see the pediatric patient who's not happy. You see his face, his smile, it's upside down. He's got lots of tears. You can look at what's happening to his arm there, what looks like blood pouring out of his body, a tremendous amount. They often view that the blood is just so dangerously leaving themselves. Look at the arm. They actually have a restraint on one of the arms, and what must be the needle, not a sword, looks like a sword from this care provider who looks quite scary. But outside it looks happy. Inside, all very dark, but outside it looks like there's hope there. This is their perspective of what it's like to be a patient. What a terrible, terrible thing. We're there to help these kids. We're there to make them feel better. And this is their perspective about this. So we need to keep this in mind, that they don't understand and appreciate our intentions always. And we have to keep this in mind when we're trying to make them feel better. So try to do a couple of just really simple things. Keep them upright whenever you can. Touch them in a comforting way. Keep the equipment out of view until used, particularly needles and syringes. When they see some blood coming out, you've got to remind them, oh, that's a little bit of blood. It's okay. You've got lots of blood. That'll be all right. Don't force them to look away. There are some patients that actually feel more anxious if they can't see the thing that they're afraid of. You can always use a cool compress prior to injections. You can always use distraction, although that's an art as well, and try to keep the parents present if they are coached to be effective and helpful. Best things are to do things that you minimize intrusive painful procedures, that you welcome the parents, that patients are prepared, that you use special rooms so that they don't feel vulnerable in the rooms that they stay in, that we have people there that can help, whether it's Child Life or someone else, and that they're in a what we call a position for comfort. This is an example of position for comfort. This is lumbar puncture on one of our oncology patients. And in this case, the child is being hugged by his mother, who's holding him in a comforting way, and he's sitting upright. He's not laying flat. So he doesn't feel as vulnerable as he might if he was forced to lie down in a fetal position. Similarly, this is a child who's going to get an IV placed. She's not lying flat looking up at people. She's almost at eye level with everybody else, and she's sitting in her mom's lap. All right, here's another case. This one it provokes a lot of controversy in my environment for sure. This is a 1-year-old female with 4 days of fever, loose stools, vomiting now, and you decide we just got to make sure she doesn't have a bladder infection. So the parents ask, is this going to be painful? Are there any long-term effects? Are you just going to do it, or are you going to do something for it? So would you say, no, this won't hurt, and she won't remember anything? Yeah, it'll be a little uncomfortable, but we never give any medicine, so it'll be fine. Or, oh yeah, this is really uncomfortable. We might give her some laughing gas or some oral midazolam, or how about some propofol or ketamine? How far would you go? What are your thoughts about this one? A, B, C, or D for a bladder catheterization? So I see a vote for C. I love that, option C. Although personally, I might vote for D if it was on me. That's just me. So I love that you all are thinking about C. I will tell you that this is my routine practice. I always offer and encourage parents to accept either midazolam or nitrous oxide, because this is an invasive procedure. Now, it's hard to do a randomized controlled trial to see which experience is worse for boys or girls. My bias is that this is most likely more painful for boys, but still quite uncomfortable or painful for girls as well, having not personally experienced this as a girl. And there's no reason why I can't do a little bit of something to make this easier. And I will tell you that the experience I have with my nursing staff, who is often skeptical about, why are you doing this? We just hold them down and do this anyway, is that after I give them midazolam for this, the nurses will tell me that was the easiest catheterization I've ever done. And it's no surprise, because we've totally relaxed them. We've taken away their anxiety about what we're doing, which makes sense that they would be anxious to be put in this position. It does not take away the pain, however. And so lidocaine gel could be useful as a topical anesthetic. It'll still be quite uncomfortable, but this will be easier, and perhaps there'll be some loss of the memory for that procedure. I'm going to forge ahead to case 11 in the interest of time. Let's see if my computer can cooperate with this. We have a few more cases to go through and then have a group discussion about this. This section really gets into the physiology of pain and probably deserves its own hour of a lecture. Now my computer doesn't want to go any further because it's tired. Here we go. Here we go. All right. An anxious 6-year-old needs a reduction of a fracture. He's had an allergic reaction to fentanyl before. Okay. So you want to use ketamine. And the parents say, yeah, but he has esophageal varices. Well, maybe I don't want to use ketamine. I don't know. So would you pre-medicate him with Zofran and then use the ketamine at 1.5 per kilo IV? Would you pre-medicate him with some pain medicine and then use ketamine 1 per kilo? Would you give him 1 per kilo ketamine followed by propofol? Or would you do a nerve block and then possibly sedate him with propofol? What would you do? You've got a 6-year-old, you've got a painful procedure to do. You're worried about causing vomiting and you know that ketamine might do it. What are your options? And if you don't like any of those answers, which one would you choose? I see some votes for C. So as you may experience in your practice with ketamine, there is a significant, not everyone vomits, but it's a high rate. And for the most part, that's a very miserable experience. But in this case, it could be dangerous. So I would want to avoid doing anything that might cause his varices to get worse, if possible. But the challenge is that I can't use fentanyl for this alleged allergy. So what could I do? One answer would be to do a femoral nerve block. A femoral nerve block could anesthetize them well, and you wouldn't feel a thing if you feel comfortable in doing that. Another option certainly is to pre-medicate with Zofran, but studies have shown that that doesn't seem to decrease the incidence of the vomiting from ketamine. So I commonly will use it knowing that it probably doesn't have a lot of effect, but it doesn't have a lot of downside. But pre-medicating with an opioid can decrease how much ketamine you need. And if you use a lower dose of ketamine, you probably will have a lower risk of vomiting. But it's hard to know. People are different and every experience is different. So all of these answers are challenging. It's a challenging situation. But it is important to recognize the limitations of our treatments. And ketamine, while an amazing drug, does have some limitations in its application. All right. You are visiting a friend of yours in the hospital who has just delivered a healthy baby boy, and she asks you about how much a circumcision will hurt her infant and what can be done to make it not hurt. And so I will tell you, in the US, it is very common to have circumcisions routinely done. That's not true for all patients and all cultures, but for the most part, it's common. So would you say, well, there's no evidence that a circumcision hurts any more than just being cold or hungry, so it's okay? Or B, it probably hurts, but there's no evidence that infants will remember pain, so don't worry about it. C, well, topical anesthetic creams could help, and they use this sucrose solution that takes away the pain, or I don't even want to talk about it. What would you say to a patient like this? How would you answer their question about circumcision for their baby, knowing that you're the medical expert? And if you have a different answer, go ahead. Yeah, so topical anesthetic creams and sucrose solution, and that is an option for sure. Not commonly routinely used in the US, but in some institutions it's used. Sucrose solution is used very commonly. It is interesting, though, that there are many people that would probably answer some form of B, that there's no evidence that they remember pain, so it probably doesn't matter. And many that would answer A, that, babies cry with so many things. They cry when they're cold, they cry when they're hungry, so we probably don't see much difference. It's not going to be a big deal. There is evidence that that's not correct, so I want to talk about that. We talked about this a little bit at the top of the hour. There is this dogma that there's no evidence that infants can recall pain. And of course, I call it dogma. However, we don't get it to tell us their experience, so it is hard to know. But we do have some physiologic evidence that they do experience it. So if you look in both the human population and also in the animal laboratory population, that premature infants and newborns show a different response when you have repeated stimulation. So if you have a rat pup and you poke them, or a newborn baby who's in the NICU who's getting repeated blood draws for glucose checks, for example, they will have a brisker response. If you get repeated pokes, they're going to have a brisker and brisker flexor response. And infants as young as 1 will react to the sight of a needle, clearly remembering that that is a dangerous thing. Where do they get that from? There must be some kind of memory. There's this fascinating study that I want you to know about that was published in Lancet 1997. So Anna Taddeo is a pharmacist who was doing a study on what was then a new product called EMLA, topical anesthetic. And it was not about circumcision. It was actually about vaccinations. She was trying to see, would it help in the discomfort in babies who are getting their vaccinations at 2, 4, and 6 months? And she found that there was a difference, but not in all the babies. It was simply that there was an incidence that there was a difference in whether or not there were boys or girls getting the vaccinations, that was a profound impact. She looked this and she said, well, what is it about the boys that makes them different? And it wasn't all the boys, it was just the boys that were circumcised. So she did the study again. And instead of looking just at their pain and vaccination, she also looked at what is the impact of using EMLA prior to circumcision. So they covered the foreskin, and they found that at the vaccination time, that the boy babies that had EMLA applied at the time, not with the circumcision experience, but with the vaccination experience, 2, 4, and 6 months later, cried much less than the boys who didn't get anything at all. So they seem to have some evidence of physiologic memory to the experience that they had, whether or not it was adequately treated at the time of birth when they got circumcision. All right, I think we have just a few more to go. And we are doing okay on time. I think we have like 5 more minutes. All right. A 13-year-old girl complains of severe right foot pain 2 weeks after twisting her right ankle during a soccer game. She has not placed any weight on the right leg since the injury and currently cannot tolerate wearing a sock on that foot. X-rays and ultrasound were negative. What is the diagnosis and what is the treatment? Now, I will tell you, just by coincidence, I made this diagnosis just yesterday on a similar patient. Oops, I'm going to go back now. Let's see. So anybody, if you can, chime in and see what you think about this. What do you think is going on with this patient? So someone suggests a sprain. So, what's peculiar about this patient, though, is that she can't tolerate wearing a sock. In fact, it's not only a sock. When you walk by, she screams. She screams that the breeze that you created by walking by caused her pain to escalate. And her pain waxes and wanes dramatically. And she describes the pain as burning, almost like electric sensations. And it's all over. And she's in agony, absolute agony. And it's weird how this redness and swelling is so focal in nature. But no evidence of a break, no evidence of an infection. So this is a condition that we don't see every day for sure. But I did see this yesterday in a similar kind of patient, an 11-year-old girl. And this is something that I think represents a uncommon but an important to recognize condition. And this is neuropathic pain. The now older term is complex regional pain syndrome. Another old term is reflex sympathetic dystrophy. And in this condition, the nerves are the problem. This is pain out of proportion to any evidence of injury. And it's a pain that is experienced in a very peculiar way, where they are feeling something that is lightning sensation or burning sensation, which is the hallmark of neuropathic pain. And you will hunt and hunt for the organic cause of this. to no avail, because you will not see results of this in a blood test or an x-ray, but it's a clinical condition, and it's a terrible condition. This condition manifests in kids, typically in young teenage girls, and in adults, in men, and it manifests not in the leg so much as at the wrist. In fact, one of my colleagues was disabled by this for many years before he could get back to work. This condition requires a multimodal approach. There is a role for medicines, but not for opiates, typically medicines such as Neurontin or gabapentin, and others. It benefits from physical therapy, which is quite difficult because they have to desensitize the patient, and from cognitive behavioral therapy strategies. So we have psychology, physical therapy, and also a pain specialist involved in their care. And these patients are often going from doctor to doctor until someone recognizes, oh, I know what this is. This is a condition that's a little bit different than what we learned about in medical school. All right, I think one or two more, maybe one more case. Let's see how we're doing on time. Yeah, one more case, absolutely. All right, so this is one of my first patients in the emergency department at Eggleston when I began practicing 25 years ago. A 9-year-old boy who was brought in by EMS with apparent injuries to his abdomen, his head, his thigh. His Glasgow Coma Scale is 15. He's screaming. So he's got a lot of injuries. This is what happened to this kid was that he was riding a skateboard and he crossed the street. And when he crossed the street, he got hit by a car. And so now he's got injuries, high impact injuries to multiple parts of his body, and he's in a lot of pain. Are you willing to give him a pain medicine, or do you want to wait until you finish the evaluation? And if so, what kind of pain medicine would you use, if you use anything at all? What are your thoughts about that? And I would say that this is a little less controversial now than it was 25 years ago when I first saw this patient. I also will never forget that what this particular patient said to me was that it hurt so much worse than the last time he did the very same thing. So this wasn't the first time this kid got hit. He turned out all right, by the way. He did okay. He looks worse than he really was. But there's always some reticence about whether or not it's safe to give him some strong pain medicine. So what do we do about this? So it's important to have a fundamental understanding about opioids. We'll talk about that just for a few minutes. Opioids block pain impulses in the central nervous system via some receptors, and there are a variety of them. Now, principally, we're talking about mu receptors, but also there are sigma, delta, and kappa receptors, and all of them have a different part in the treatment strategies that we use. We like to use fentanyl for acute pain relief when we have it available because it is quick, it is reversible, it's potent, but it does have some problems. So one of the things that it can do is cause some bradycardia in patients. So if you already have a bradycardic patient, that might be dangerous. And in infants, it might cause something called chest wall rigidity. This is something I haven't seen in a long time, but I haven't used fentanyl as much as I used to now with other options. But what happens is that typically in a baby, you will see that they're ventilating fine, and then suddenly they just can't ventilate. And you have to be prepared to intubate them. It's an idiosyncratic reaction. We try to give fentanyl slowly to prevent it, but it can happen to any patient, typically the younger ones. We like fentanyl because it works fast, but it does take 5 minutes. So it's important for people to be able to wait 5 minutes before redosing, or you're going to stack the medicine. It can last for half an hour, linger for an hour, but then it's gone. Dosing, it's important to dose at good doses, meaning that if you use a very timid dose, you will end up needing to give repeated dosing and then stacking your medicine. So start out with a 1 to 3 mic per kilo dose, depending on the situation, and then titrate to effect. IV or intranasal. We know that opiates do a number of things. They certainly can block pain responses, but they also seem to help you prevent the development of chronic pain for a number of reasons. One is that they seem to block areas where we consolidate traumatic memory, and then there are a number of studies that suggest that people who are treated in the acute phase of pain very effectively have lower rates of PTSD than those who aren't, even if they subsequently get adequate pain, meaning that what you do in the moment with severe pain can have profound impact later on in life. So this is one study that substantiates that by Glenn Sachs, who looked at patients who were in a burn unit 6 months later, and that means they were really bad, and they found an inverse relationship between the PTSD symptoms and the amount of morphine received in a milligram per kilogram basis. All right, I am going to stop sharing my screen because I think we promised to stop by now and open it up to discussions. I'd love to know about your own pain experiences, your challenges, and what do you think about all of this?
Thank you, Mike, for picking up about a few cases which we could manage or we're supposed to manage. The good thing, like most of the cases, we have a plan. The planning, including the strategies, but as well as the standard of how we should manage this. So, colleagues, back to you. Share your experience, questions, comments before we wind up the discussion. Chair, it's all yours.
Okay, thank you very much, all our keynote speakers, Dr. Said and Dr. Mike. So it's now time the participants have time to at least give their views, give opinions, and also experience. So for anyone who will wish to give an experience or ask a question, you are warmly welcome to just unmute your mic and ask.
I'm curious about what you all experience on a regular basis in pain management and where you found yourself wondering, is there a better way to do this, or concerned that maybe this isn't the best way, or not. What goes well? What do you think you do particularly well? But this is often a challenge for us in our everyday practice.
Okay, I see there is a question in the chat. So the question is, yeah, is it possible to give anti-pain to a 3-month-old child who is brought at ED for chief complaint of excessive crying without history of trauma or any injury? Back
So,
to you,
yeah, I would be reticent to just start with pain medicine before exploring these options. What is it about the situation that might lead me to understand why they're crying a lot? Are they crying because they have terrible reflux? Are they crying because they're hungry, or maybe they were injured? I think that we need to find out what's going on. I think that's probably fine to give a 3-month-old a dose of acetaminophen or paracetamol. We generally avoid ibuprofen under 6 months of age. But I probably would be more curious about why the child is persistently crying out of nowhere. Is this a behavior that they've had before? Are they colicky? Because you want to be able to give them the best possible treatment. But I suppose there's nothing wrong with giving some acetaminophen or paracetamol. But why is this baby crying so much? What's different about it? So the diagnosis is going to be particularly important in that case. Who else has a thought about that or other cases? How to give nitrous oxide in the ED. Okay. So we didn't always have nitrous oxide in our ED. I had to go to another hospital, a children's hospital that had already established the practice. So it does require some learning some new skills and understanding the medicine, but it's something that I did in my available time. It was not very cumbersome. And then, of course, purchasing the equipment. So we have a portable blender that has a tank of oxygen and a tank of nitrous oxide, so it does not require walled-in nitrous oxide. Nitrous oxide is used throughout the world in many situations, in dentist's office routinely in the US, in pre-hospital care around the world. So very often ambulances in many parts of the world will have nitrous oxide to manage pain en route. It is something that it can be safe and effective when people are trained. What we've experienced in our institution is that we have a handful of physicians who have embraced this and learned how to do it and feel comfortable. But if you have not learned how to do it, you're not going to consider the option. So like many skills, if you didn't learn it already in training, you have to acquire it afterwards. So that's a challenge to get physicians who are already trained to learn something new sometimes. But once they do, it's a great adjunct. I will tell you that I have never seen nitrous fail to help me get an IV. And I can't say that about anything else. But what nitrous oxide can do is dilate the veins. So not only does it make a child feel better, but it dilates veins. So accessing a vein makes it so much easier and their experience is so much better. Has many potential uses. Is not a very strong analgesic, but it has analgesic properties, but can be a wonderful adjunct when you get used to it. So it does require someone to just say, I'm going to learn how to do that and bring that to my institution. And what are the common side effects you have encountered? So if we're talking about, so the question above it was, what are the options for multimodal pain management for sickle cell patients in pain crisis not responding to morphine? Great. And what are the common side effects you have encountered? I don't know common side effects to what, if it's to nitrous oxide.
Nitrous oxide.
Nitrous, okay. So the number one side effect from the nitrous oxide that I see most commonly is going to be nausea and vomiting. And you typically have a small window. You can recognize that that's going to happen from the expression on a child's face. So if you go too fast or too high in your nitrous oxide concentration, you will make them nauseous. It does have some other side effects, and there are also some contraindications. And the main ones that are practical are the possibility that you might cause air to expand in an area it shouldn't. So for example, a patient that has a small pneumothorax, if you give them nitrous oxide, that air might expand and become a tension pneumothorax. So anyone that's had a trauma or has had a major body cavity surgery in the past month should not have nitrous oxide. So that's one of the considerations that we have. In addition, ocular surgery as well. We wouldn't want that to happen. Interestingly, one children's hospital here found that the incidence of nausea and vomiting was decreased if they ate a little bit of food before getting it, meaning that the kids with the empty stomach vomited more than those with the non-empty stomach. The incidence of vomiting and nitrous oxide is still quite low. It is probably in the order of 5%. But seeing it one time as a provider makes you not want to use nitrous oxide ever again because they will vomit in the mask. So it's rather distasteful, to say the least. But most of the time you don't see that. And if you are careful with nitrous and you are watching your patient, you'll know when you've gone too far and too high and you just back off. Most patients do not vomit. There are some other side effects that you might see too. You might see some flushing and some other side effects, but for the most part, it's well tolerated and wears off as quickly as it kicks in, meaning that within 3 minutes, it's out of their system. They are safe to walk around. And so it's a pretty safe drug. There has never been a report of an allergic reaction to nitrous oxide. Never been. Let's see, Dr. Murray pointed out that nitrous oxide is available. So I'm looking, great. So I see one more question about, yeah, we are on time. Just one quick mention about burn patients. One of the most effective things that I use for burn patients for second-degree burns is topical lidocaine. Yes, I use other adjuncts too. I will give them hydrocodone. I'll give them ibuprofen and sometimes more, but topical lidocaine takes away the pain so beautifully, and I can do so many things without causing pain. But nitrous can be a nice adjunct for this as well. All right, so I'm told that our time is up. Thank you so much for the discussion. I appreciate the invitation.
Okay, thank you very much, our presenters, for a very nice topic and a very engaging topic. And we're happy that today the participants have also had chance to participate in the presentations and to give out their views and questions. So we are right on time, and we'll just leave the chat open so as to make sure that if there is anyone who has not yet written down their name and the MCT number for the CPD points, they can do that right now. Just a reminder for all those that will be waiting for the CPD points, just make sure that you do not have any debt at MCT, because then it will be difficult to get the CPD point. But as well, majority of you have been asking how is it that we can really get these lectures and probably for reference and as a part of learning. So I've just shared with you on the chat. We have all these videos uploaded in our YouTube channel so that everybody could watch them and learn from all the previous lecture series that we have had and the ones that we'll be having continuously every month. So just to highlight you, our next PEM lecture series, which is going to be lecture series 8, is going to be next month, and it's going to be on a very interesting topic, that is pediatric toxicology. So just stay tuned. We'll give you the updates and let you know the exact date that we're going to have our next lecture series. So thank you all for joining in, and we would like to wish you a very good evening for us in Tanzania and a very good morning for those in US.
Thank you.
Thank you, everyone.